Hello everybody and welcome back to Desert Docs, a junior doctor's guide to Central Australia. Today we've got a renal few episodes coming and we've got Dr Anosh, a dual cardiology and gen med advanced trainee at Alice Springs Hospital to help us out with those episodes. Hello Anosh.
Hi Indi, how are you? Thanks for having me on board.
No worries, I think it'll be a great couple of episodes. Firstly, I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country and that we work on their stolen lands. Just in terms of setting the scene for these renal episodes, we'll be doing an episode on chronic kidney disease, haemodialysis and missed haemodialysis. And today we're going to go through chronic kidney disease in Central Australia. Alice Springs has the highest burden of chronic kidney disease in the world. Renal medicine is also not just limited to those doing a renal rotation at Alice Springs Hospital. Even if you're on a gen med or surge term, adjustments for a patient's renal impairment and interventions to prevent progression of chronic kidney disease is a whole hospital approach, including in primary care. Anosh, let's firstly talk about the basics of chronic kidney disease. What is it? What are the stages? Why do we see so much of it in Central Australia and how do we manage it? Sorry for the big question.
No, all good, Indy. Thanks. That's a great question. And I think as you sort of pointed out, it is a very eye-opening disease and something that we do need to sort of pay close attention to and have a brief understanding of it so we know how to best tackle and manage it. So chronic kidney disease, as the name suggests, is a chronic indolent process, and it's something that we do need to think about in terms of the underlying causes. In terms of the definition of CKD or chronic kidney disease, essentially it's kidney disease that refers to progressive loss of nephrons and subsequent functions that I'll talk about a bit in regards to what the kidneys do, and that's over a 3-month period. Usually we try and categorize the stages of chronic kidney disease by 2 factors, one by the eGFR or estimated glomerular filtration rate, and one by the degree of albuminuria or proteinuria. Firstly, in regards to breaking it down in terms of eGFR, we refer to stage 1 CKD as that of an eGFR greater than 90, but with evidence of albuminuria or proteinuria, and as I said, has to have progressed over a 3-month period. In terms of stage 2 CKD, that refers to an eGFR of 60 to 90. Stage 3A is 45 to 49. Stage 3B is 30 to 44. Stage 4 is 15 to 29. And then stage 5 or end-stage renal failure is where your eGFR is less than 15. In regards to the degree of albuminuria, we have a grading scale from A1 to A4. And that's based on the amount of albuminuria, as I was alluding to before, and it's measured in milligrams per millimole. In terms of A1, that's categorized as 0 to 3. A2 is 3 to 30. A3 is 30 to 300. And then A4 is above 300. So a lot of the times when you review notes, whether it's through the emergency department, after hours, clinic specialist letters, you will see people categorized as CKD into both a stage from 1 to 5, as I talked about, along with obviously the degree of albuminuria. And it's important to know about the stages because that also correlates with the symptoms that people experience. And in general, those in sort of stage 1 to 3A generally are relatively asymptomatic and a lot of the time may not have any significant functional limitation and as a result may not present to hospital. But it's also important to be proactive with these people because we want to try and minimize progression, as Indy talked about, from getting to worsening stages of chronic kidney disease, because that obviously carries complications, which I'll talk about soon. In terms of the albuminuria, that's known to be an independent risk factor, not only from a renal perspective, but also from a cardiovascular perspective. And albuminuria is a single risk factor for cardiovascular morbidity and mortality. And we also do know that albuminuria and proteinuria normally predate the actual glomerular filtration function loss. And so it's important to get on top of that early to try and reduce other issues with regards to hyperfiltration and kidney damage. The other thing I'd like to go on from here is to talk about, I guess, the underlying causes of chronic kidney disease. Worldwide, the 3 most common causes are type 2 diabetes, mellitus, hypertension, as well as chronic glomerulonephritis, and I probably should mention type 1 diabetes as well, so any form of diabetes mellitus. So those are the three common causes. And again, here in Central Australia, especially in Alice Springs, we see an abundance of diabetes, mellitus, and hypertension. So it's important because we need to think about optimizing these risk factors, not just from a kidney disease perspective, but also from a cardiovascular, cerebrovascular, and peripheral vascular perspective, because they obviously have attached with it a lot of morbidity and mortality. In terms of other causes of chronic kidney disease, especially in Central Australia, you do need to think about conditions such as post-streptococcal glomerulonephritis, which unfortunately does affect a lot of our younger Aboriginal and Torres Strait Islander populations, in addition to rheumatic heart disease with the group A beta hemolytic streptococcus. You also need to think about people who've had recurrent skin infections, septic episodes, or recurrent episodes of an acute kidney injury. All these factors, in addition to underlying renal vascular diseases such as hypertension and diabetes, increases their propensity to develop into chronic kidney disease. So this is more from the medical perspective, but it's also important right now to reflect on the social determinants of health, because a lot of these factors are basically all working together to contribute to the culmination and progression of CKD. And in fact, the director of the renal department here, Dr. Kieran Fernandez, actually interestingly told us about a fact where through studies, the Aboriginal and Torres Strait Islander population, at least here in Central Australia, are actually born with a reduced number of nephrons compared to the Western population. And that's important to understand as to why their acceleration of renal deterioration is something that, we obviously are always aghast by when we see them in emergency department with, severe renal failure. But it's important to even be more proactive and try to, get down to the bottom of what's going on.
Can I ask you, Anosh, to elaborate on a couple of things there? The recurrent septic episodes and acute kidney injuries, can you explain a little bit more about how that contributes to chronic kidney disease?
Yeah. So in terms of sepsis, sepsis in itself is obviously a sort of systemic inflammatory response syndrome. And with regards to the kidneys, it can affect it in different ways. The way when you think about kidney damage, you need to think about it as pre-renal, intrarenal, and post-renal failure. In terms of pre-renal insult from the sepsis, you can get that because you can get hypotension secondary to vasodilatation from the sepsis itself, and as a result, you're going to have reduced intravascular volume, and as a result, less volume and blood pressure and filtration pressure for that matter in the kidneys. And over time, that can lead to reduced glomerular filtration. When you try to address these problems, you obviously try and help and reverse by giving fluid, giving antibiotics. But every time we get an insult, it's like a small scar, and it increases the propensity to further damage. And when you have recurrent insults, and even sometimes asymptomatic urinary tract infections, superficial skin infections such as impetigo, scabies, we take it for granted and we don't necessarily always check the kidney function, but all these insults are unfortunately leading to a likely autoimmune process like a silent subclinical glomerulonephritis. With regards to acute kidney injuries, initially we might think it's benign, but when you get repetitive insults, similar to sort of the septic picture, you can get, again, pre-renal and intrarenal issues, and it's that scarring, general reduction in nephron reserve, reduced capacity for metabolic mechanisms and the renin-angiotensin-aldosterone system to actually counterplay and do its job. All those functions start to steadily decline, and it's actually the combination of all those factors in addition to having an underlying phenotype that's causing renovascular problems like hypertension or diabetes, which accelerates it further.
Yeah. And also just another quick question about the role of SLE in the chronic kidney disease we see in Central Australia. Is that also part of the risk category for a lot of our demographic having chronic kidney disease?
Yeah, very good question, Indi. SLE was actually a condition that, obviously was noted to be affecting females, younger people, and there was actually a study by Dr. Sajeev Cherry and Dr. Kieran Fernandez and Dr. Sargent Thomas around a decade ago, where they basically had a look at the amount of SLE and lupus nephritis cases for that matter, and it was actually a disproportionate amount. Unclear in terms of the reason and whether there probably are some genetic and epigenetic variations, but there is something definitely happening here in Central Australia, and therefore it's really important to be aware of that. And you do need to have a low threshold thinking about lupus nephritis. And usually, obviously, if they're Aboriginal and Torres Strait Islander, they're young, generally would affect sort of women more than men, just terms of its preponderance. And if someone comes in with a hemoproteinuric presentation, so they've got a hotspot urine, which basically demonstrates red cell casts or dysmorphic red cells, or they've got a degree of proteinuria, we do need to think about other, not only renal manifestations of SLE, but also extrarenal manifestations and the rheumatological manifestations to come up with that early diagnosis. Because treatment early on, for example, with pulse steroids, plus or minus other agents that are steroid sparing, like CD20 inhibitors like rituximab, hydroxychloroquine, mycophenolate, and cyclophosphamide, for example, are going to be important to think about early on. And the issue with SLE is that lupus nephritis, it's quite complicated because there's 6 classes and it depends, and varies from a nephritic presentation in some to a nephrotic to an overlying nephritic and nephrotic. But look, the early diagnosis comes back down, like I said, to pretest probability. If someone has a hematoproteinuria, so blood and protein in the urine with hypertension and potentially has fluid overload from nephrotic syndrome features, you've got to think about ruling that out with an autoimmune screen early on.
Right. I never realised that's why we send a hot urine.
That's
did
right.
what I was told.
Exactly, yeah. So, yeah, it's one of those things that you'll see all the renal physicians, get excited about and their pupils get dilated, but it's understandable because it does change management quickly.
Okay, so Anosh, I've gotten you off track with my initial question there. We've talked about all of those things like the stages of chronic kidney disease and why it's so prevalent in Central Australia. So how do we manage it?
Good question. So as you can imagine, it's obviously a complex process and there are a lot of things that we need to think about. I think before we think about management, we need to think about the complications of chronic kidney disease. So I'll touch upon them briefly here. So in addition to obviously being important to filter all the blood that we do and excrete out toxins and waste such as potassium, creatinine and other wastes, there's also functions in erythropoiesis. So in other words, red cell production, because you get erythropoietin released from the peritubular interstitial cells of the outer cortex of the kidney. It's also very important for bone health because over time, as your chronic kidney disease progresses, you can get this condition called CKD-MBD, which is chronic kidney disease mineralization bone disorder, which is a syndrome of what we call adynamic and dynamic bone disease, which generally tends to happen because as your kidneys get worse, your calcium is not absorbed as well, so it gets excreted. And furthermore, the kidneys are also the final stage for active hydroxylation of vitamin D. So you don't get that calcitriol intrinsically. And as a result, there's less gut absorption of calcium. And then basically the human body senses that. And then the parathyroid glands go into overdrive and stimulate PTH or parathyroid hormone, which stimulates osteoclastic resorption of bone. You get release of calcium hydroxyapatite crystals into the bloodstream to try and compensate and therefore increase your calcium and your phosphate. So you can sort of see there that when you're a bit more acidotic, as your kidneys start getting worse, your bone sort of turnover also gets worse. You get demineralization, you're at higher risk of fractures, osteoporosis. So bone health and bone issues is something that's very important, and you'll see a lot of renal physicians talk about that. Another complication is increased cardiovascular morbidity and mortality. So there's obviously the traditional cardiovascular risk factors you've got to think about in regards to hypertension, diabetes, smoking, family history, previous history of ischemic heart disease. But there's also non-traditional risk factors that come with chronic kidney disease, and that's in regards to the abnormal calcium phosphate imbalance. And when you have issues like that, you can lead to, again, this is getting a bit fancy, but you can lead to increased levels of FGF23 and Clotho as a result, and that can also cause cardiovascular morbidity and mortality through different mechanisms as well. And there's also a role for kidneys to help with gluconeogenesis as well, in addition to the liver. So when it comes to management, it would be basically thinking about it again from the stages, as we talked about earlier in this podcast, with regards to both the estimated glomerular filtration rate as well as the degree of albuminuria. And as I said, if you're at the earlier stages, that's fine, and you pick them up early, and it's about disease modification, being proactive and getting aggressive risk factor control. When we have someone with albuminuria, just to make it simple for you guys, we obviously need to think about the underlying insult, and a lot of the time it could be in the context of diabetes, hypertension, as I said, recurrent infections, autoimmune diseases, just to name a few. And in general, it's about treating and finding the underlying disease, so that's why it's important to work out what we're dealing with. And then once we do that, we can also then add in antiproteinuric medications. The usual medications we use are your ACE inhibitors or your ARB, so that's your angiotensin converting enzyme inhibitors or your angiotensin receptor blockers, such as ramipril or valsartan. We also can then use your SGLT2 inhibitors, which are obviously up and coming, not only in the renal world, but in cardiovascular and the endocrine world as well. And then thirdly, we can use mineralocorticoid receptor antagonists such as spironolactone or finerenone. So all these things help with basically reducing the amount of albuminuria and proteinuria. And as I said, that will not only curb the progression of the renal disease and slow that down, but it will also help minimize and reduce cardiovascular morbidity and mortality. When it comes to sort of stage 3A, 3B, 4, 5, and CKD, that's when we start to think about the complications, and then we pay close attention to asking patients about that, and then also thinking about managing issues. So one of the issues is going to be obviously hypertension, because you're going to get dysregulation of the renin-angiotensin-aldosterone system. So it's about putting them on blood pressure medications that are going to be very good. And this can obviously start off with an ACE inhibitor or an ARB, as we talked about, because that will also have a dual benefit in reducing the amount of albuminuria. And then normally after that, we tend to go for good beta blockers that are helpful in CKD, and one of them is atenolol. And then after that, you're thinking about whether they need erythropoiesis support. So to decide about that, we firstly need to make sure the other hematinics are replete. So we check iron studies, vitamin B12, folate, thyroid function test. And if they're all okay and the hemoglobin is still less than 100 in a CKD, usually 4 or 5 patients, we then think about an erythropoietin stimulating agent. And the common ones we tend to use here are Aranesp or darbepoetin alpha or Mircera. The essential difference is that one can be used weekly, one can be used fortnightly, and the other one can be used monthly. But it's all about trying to maintain erythropoiesis, because obviously anemia, in addition to fatigue with progressive kidney disease, is obviously going to be significantly debilitating and sort of functionally limiting as well. And then as we get to sort of the latter stages, especially 4 and 5, we then need to think hard about whether this candidate would be a good renal replacement therapy patient. And there are 3 different types of renal replacement therapy. So the first one is, or in terms of options, the first one is obviously dialysis. And we'll obviously talk in detail about hemodialysis on another podcast. The second one is obviously thinking about whether this patient would be a transplant candidate. And in Alice Springs, there are a lot of young people, especially women more than men, which is not the usual characteristic for CKD, that are being affected. And as a result, we do need to try and work out what the best way is and see if there's any contraindications for them to be a transplant candidate. And that's a topic in itself as well. And then the third thing is there are going to be some patients who are just very frail beyond their years, very comorbid, and just physiologically are not going to be able to respond to the demands of dialysis, and in which case we might go down the sort of conservative care pathway. But these are options that we tend to discuss, at great length over multiple visits, and we incorporate a multidisciplinary approach with a CKD clinic nurse, a dietitian, physiotherapist, and also talk to the social worker. And I think it's the consensus decision which then allows us to then work out what's going on. Obviously, we incorporate the opinions and decision of the patient and their family in thinking about this, because a lot of patients may not really understand what dialysis entails. And a lot of the time we do tend to try and work out who can have it and just make sure that people don't have a contraindication.
And we'll touch on this in the following episode that Anosh alluded to about hemodialysis, but it does require our remote patients to move into town, which is a factor in itself. So, Anosh, when would we consider renal replacement therapy? I see through the emergency department quite a few people with eGFRs of 14. Is the cutoff to renal replacement therapy or hemodialysis based on eGFR or creatinine or potassium or urea or other?
Great question. And one of the difficulties, but also I guess the rewarding aspect of working here is working in an emergency department where you're seeing someone potentially for the very first time, as Indi was saying, maybe with an eGFR of 14, and then being like, what do I do now? So I think the approach here would be trying to work out, is this acute on chronic, or chronic? And it's not always entirely clear. So from an acute kidney injury perspective, as I alluded to before, you've got to think from first principles, is it pre-renal, intrarenal, post-renal? And then to try and differentiate whether it's acute or chronic, there are some factors that we sort of tend to look at, but an easy one that we tend to consider is using the ultrasound kidney ureter bladder, or ultrasound KUB. And that's very helpful because it basically marks signs of chronicity. So as your kidney goes into more chronic failure compared to acute failure, we tend to find that the kidneys become a lot smaller and atrophic. Secondly, there's also loss of the corticomedullary differentiation or junction per se. So those are features and markers of chronicity, which tells you that this probably has been, grumbling on for a while, and this person's been asymptomatic and then they present now. In terms of the indications for dialysis, that's the next thing that we think about then and there. And the mnemonic that I sort of use and also teach my fellow juniors is based on the vowels A, E, I, O, U. So A stands for acidosis. So as your kidneys get worse, your buffers are not working, especially your sodium, ammonia, hydrogen bicarbonate buffers, and you're also getting retention of potassium because you're probably not diuresing or passing urine as well. Some people initially may pass a lot of urine, some people may not pass much urine at all, and it varies depending on the phenotype and the progression and the rate of deterioration. But acidosis is very important. And the way you can indirectly look at that early is when you do a venous blood gas, you look at the bicarbonate. And acidosis is not just about saying, right, they need dialysis, but it also is important to try and correct because it can also lead to hypokalemia. It can also lead to cardiac stunning, and people can get hypotension and transient LV global dysfunction. And it can even also sort of obviously subacutely cause to bone decline in the context of CKD, MBD. So that's acidosis. And we try to correct that early on with sodium bicarbonate or Sodibic. But again, if someone's quite fluid overloaded, you need to be careful because the sodium is a very osmotically active agent. Fluid follows it. So again, it depends on that patient, and that's where you need to sort of titrate the idiosyncrasies with that particular person in front of you. The E is electrolyte imbalances. So namely, potassium goes up, your sodium can go down as you get more and more fluid overloaded as a result of kidneys not excreting water and fluid. And as a result, that's something that you need to address. Important to get the potassium down, obviously, for many reasons, but mainly for the cardiac side initially, about membrane stabilization. There are several agents and medications that we can use to do that. In this case, if someone's hypokalemic, we look at their ECG. I wouldn't say that there's a certain number at which point we would say that they need dialysis or not, because we try to medically optimize it and get it down. If obviously we are struggling with medical management, it's at that point where we may need dialysis because that will be our last option. And that may be very well an acute indication in someone. The I in AEIOU refers to intoxication, and that actually opens up another mnemonic called slime, which is intoxication with several substances. Slime being salicylates, lithium, isopropanol substances, methanol, and ethylene glycol. So all these substances, just based on their sort of molecular and sizes and the dialysis membrane, need to be dialyzed off if you get, for example, an overdose of one of those. O, going back to the initial mnemonic, is fluid overload. That's refractory to diuresis with furosemide. And then U is uremia. And whilst I'm on this, it's really important to know that a lot of people think that uremia is elevated urea in the blood, and it's not. So the biochemical elevation of urea in the blood is referred to as azotemia. Uremia is azotemia plus a clinical constellation of symptoms as a result of elevated urea in the blood. And that can manifest as someone with confusion in the context of uremic encephalopathy, chest pain in the context of hemorrhagic pericarditis, increased bleeding as a result of urinary platelet dysfunction. So those are the features that you think about in terms of whether you would take this person for dialysis. So it's not just a one number thing, it's a combination of factors, how much of it is reversible, but then also thinking about their age, their functional status, their social and geographical factors, because starting dialysis may be easy for us because we're able to put in a catheter and dialyze them, for example, acutely in intensive care unit and maybe then send them to the wards. But we need to think about whether this person would want that. Firstly, what else is going on? And so a lot of the times we're involving their family because they may not be well enough to talk, just to get a collateral history, let them know about the situation, also involving a social worker, an Aboriginal liaison officer, and then thinking about whether A, they would be a candidate for dialysis, and B, is it a short-term or a long-term option?
Do you know when you start it whether it will be short-term or long-term, or you just have to see after you begin it?
I think if someone presents in extremis and is in renal failure with one of those or one or more of those indications, we obviously do tend to start it, especially if there's no obvious, life-limiting comorbidities such as very advanced malignancy, severe frailty, and sort of functional impairment. Those are the things that we sort of look at, and then obviously we start at trying to get them a bit better, and then think a bit about discussing with the patient and obviously their family about the longer-term options.
Mm-hmm. Anosh, I think I took you off topic a bit earlier when we were talking about the management of chronic kidney disease before we get to that acute needing of renal replacement therapy that we were just talking about. We did mention that you would want to stop the progression of CKD, putting in an ACE inhibitor or an ARB to reduce proteinuria. There are a few other interventions that we can do to stop the progression. Can you expand on that?
Yeah, sure. So we talked a bit about sodium bicarbonate before and the importance of helping with acidosis. And usually as per what we call the KDIGO guidelines that we tend to sort of follow here in Australia, it's normally when you get it to a level of bicarbonate being less than 18 when we start to think about whether we would consider commencing sodium bicarbonate. And in terms of the dose, we normally sort of go at sodium bicarbonate 640 milligrams twice daily, and then we can up titrate depending on the response. The next important thing to discuss is phosphate binders. So again, as a result of reduction in phosphate excretion, as well as a buildup of phosphate through your calcium hydroxyapatite crystals, your phosphate can go up. And the importance of phosphate being up is that it can basically bind and chelate calcium. So the actual manifestations and problems that we get is a result of hypocalcemia, which obviously can be wide-ranging from cardiac issues to tetany to Schofstedt sign, Trousseau sign, and whatnot. So it's important to get the phosphate to a reasonable level, but also it's important because phosphate, when going up, as I talked about, can be an independent cardiovascular risk factor as well with the calcium and phosphate balance. So the binders we tend to use are sort of classed into sort of what we call calcium binders or non-calcium binders. So the usual one, first line PBS here, is calcium carbonate, and that is basically given to help bind the phosphate. It obviously can help a little bit with obviously increasing up your corrected calcium, but the main role is to bind the calcium. The issue is over time, we have to be careful because as CKD progresses, you get increased vascular dystrophic calcification in the vessels, which again, unfortunately, does increase your cardiovascular total absolute risk. And so in some people, we do need to switch them to non-calcium binders, and they're called sevelamer or lanthanum, and they, again, do a similar thing in sort of helping bind the phosphate. In terms of calcium replacement, it is complicated because normally as renal failure progresses, you get a renal loss of calcium, so you get severe hypocalcemia. And to work out the severity, we normally do a 12-lead ECG and look at their QT interval, because the QT interval can get prolonged with severe hypocalcemia. Again, obviously with all the other signs that you would consider looking at for hypocalcemia. And in terms of replacing that, if it's really bad, especially with prolonged QT, depending on the chronicity, we may even need to start off with intravenous calcium replacement with calcium chloride or calcium gluconate, and then obviously supplement that with oral caltrate or basically sort of calcium carbonate. But the longer term issue is obviously, as I talked about, the loss of active hydroxylation of vitamin D in the kidney. So the reason we give calcitriol is to try and basically fill in that gap where you don't have the kidney doing that. And as a result, you get more calcium binding in the gut and help reduce the amount of PTH being released, less osteoclastic bone resorption, and hopefully try and help some of that calcium phosphate balance. Thirdly, frusemide is obviously an agent that you'll see some of our CKD patients come in on. And it's important always with every CKD patient, whoever presents into emergency department, always to ask about their urine output and whether it's the same amount as, a few weeks or months ago. Has it got less than usual, or, is it more than usual? And frusemide is an important medication. It's a loop diuretic, and as you may all know, it works on the ascending thick loop of Henle and disrupts the osmotic gradient. And so it is a good marker for us if someone is responsive to frusemide, that they've got reasonable glomerular filtration to go from the glomerulus to the glomerular basement membrane down the loops of Henle and then up to the ascending thick loop to actually sort of get that effect. It's when we get to the latter stages with nephron loss and progressive deterioration where frusemide may not be working as much. They might become anuric, oliguric, or anephric, and as a result, we then will need to consider dialysis to remove that fluid overload.
Yeah.
So those are, I guess, some of the other things in addition to what I was talking about before that will be important to think about in terms of management of CKD complications.
Yeah, great. Just to summarize for the listeners, in addition to lifestyle interventions to stop the progression of CKD, so ceasing smoking, physical activity, healthy diet and weight management, also managing your diabetes and hypertension, including antiproteinuric medications, sodium bicarbonate, phosphate binders, calcium replacement and furosemide, your mainstay medications. On the topic of medications, and this will probably be our final question for the CKD episode, renal impairment on the wards requires different doses of a few different categories of medications, so anticoagulants being one, sometimes antibiotics and analgesia. Anosh, can you speak to the medication changes that we need to make with people who have chronic kidney disease and a degree of renal impairment?
Yeah, no worries. So this is something that we get frequently consulted about, and it's important to understand because you don't want to be giving medications at either the wrong dose or the wrong medication for that matter in someone with kidney failure, especially if you're trying to prevent progression of kidney disease. Firstly, I think anticoagulants are important to touch upon. There's obviously enoxaparin that we can consider giving, and we give that routinely in the hospital all over for DVT prophylaxis or VT chemoprophylaxis. And usually in someone with an estimated glomerular filtration or creatinine clearance of less than 30, we tend to sort of half the dose of enoxaparin or clexane from 40 milligrams daily to 20 milligrams daily. But again, that also needs to take into account the person's lean body weight as well. If you're really unsure, and they obviously can have DVT prophylaxis and eGFRs like less than 15, then it may very well much be safer to consider giving heparin, 5,000 units BD. And also, you need to think about what this patient is being admitted for, and if there's any potential chance of surgery, I tend to go with heparin 5,000 units BD. And again, that's also based on weight. Could even go down to 2,500 BD or even 5,000 TDS. And again, there are a lot of online calculators for that. And the reason you want to use heparin in terms of perioperative timing with surgery is that if you do need to reverse it, you can give the agent, as you know, protamine sulfate. In terms of the next medication class, it's important. We need to think about antibiotics. So there's obviously changes that we need to think about. And in general, we tend to either reduce the dose or reduce the frequency of medications. If they are on hemodialysis, for example, 3 times a week, one of the medications we tend to consider giving commonly for a lot of different infective processes is cefazolin. You can either give that 1 gram daily, or you can change it to 2 grams post-hemodialysis. And that's just because you want to try and minimize the amount of nephrotoxicity that you're getting at the level of the tubules and the interstitium that may then lead to other issues such as acute interstitial nephritis or toxic acute tubular necrosis. And so all those things are very important to try and avoid. Vancomycin is another one that you will see often in the renal realm, just because there's a lot of MRSA colonization infections here in Central Australia. And we tend to give a loading dose of 20 to 25 milligrams per kilogram initially, with a maximum of no more than 2 grams as the initial load, just to get it into the steady state. And then we tend to then use a nomogram, where we check the vancomycin trough levels post-hemodialysis, and usually aim for a target of 15 to 20 in terms of the overall level. And then we tend to give it based on that. And that could be anywhere from 500 milligrams all the way to 1.5 grams. And again, it also depends in terms of what type of surgery or infection you're dealing with. The third medication class is analgesia. There's obviously a lot of consternation about what should be used. In general, you have to be very, very careful about using non-steroidal anti-inflammatory drugs. I think that's very, very important. And so, yes, you can think about the World Health Organization analgesic ladder and think about up-titrating from paracetamol up. And usually the second line is your non-steroidal anti-inflammatories. But in someone with kidney disease, you have to be careful because it can obviously lead to issues with afferent arteriolar vasoconstriction, reduction in your glomerular filtration rate. And when you especially combine that with that triple whammy that we talk about of diuretics plus or minus ACE inhibitors, then you can run into a lot of trouble with regards to overactivation of the RAS cascade, reduction in your GFR, and then just progression of kidney disease. So what therefore do you give, I guess, for people who have kidney disease and have pain? It depends on, again, the type of pain, but also what agents can be considered. If someone's got an acute pain crisis, the options that I normally tend to go about are sublingual buprenorphine, which is relatively safe, or fentanyl subcutaneous on the ward. Obviously, if you're in an ICU surgical or anesthetic setting, you can obviously consider giving IV fentanyl, which can obviously act quite quickly. The beauty with buprenorphine, especially acutely, is that it's got a relatively quick sort of onset of action, but also you can then pair it up with a longer acting agent once their acute pain crisis is sorted out with, for example, a transdermal application or what they call the Norspan patch, which is buprenorphine. And the advantage of why I use it in kidney failure is that it's excreted in the feces and the bile. So there's actually no renal metabolism of that drug. So this is obviously a small sort of caveat that you can consider. Endone is not a bad idea as well, but having said that, my experience here, especially in Alice Springs, is that it does increase the risk of addiction and dependence. And so our renal consultants tend to prefer buprenorphine, either, like I said, sublingually, transdermally, or fentanyl as required. But again, as I said, it's important to work out the type of pain, such as, is it nociceptive, is it neuropathic, is it acute, is it chronic, and then also think about non-pharmacological agents importantly as well in this sort of setting. But don't worry, all of this may sound quite overwhelming to you. There are fantastic resources online, including in Alice Springs, when you start working, the Renal Drug Dosing Handbook, which basically spits out to you exactly what dose and frequency of each medication is safe to be given. There's obviously also MIMS, up-to-date Australian Medicine Handbook. And don't forget, there's obviously senior registrars, consultants, and our friendly pharmacist on the ward. Always important to ask, especially when it comes to renal failure and dosing of medications.
Thanks, Anosh, so much for talking us through chronic kidney disease. That wraps up the first episode of our renal series on Desert Docs. Thank you again for coming.
No worries. Thanks for having me, Indi.
Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.